Please start.
Yes. Yeah. So, one moment. So, good evening, everyone. It gives us immense pleasure to have you all at this hour of the night. Every weekend, it has been a successful attempt for us to bring in the Zoom sessions for the students of the Northeast as well as the national students who are willing to join us at this hour. This is a weekend session that we had been having since the last COVID lockdown, and we are still streaming on it. I would like to thank Dr. Divakan Mishra, the Secretary of Young Ophthalmology Society of India, who has been very supportive in these sessions. And today, for the first time, we are going on live on YouTube because of all his efforts. Thank you so much, Dr. Divakan. Unfortunately, we could not have Dr. Digvijay, the President of Young Ophthalmology Society of India, because of this COVID incidents and all. So the topic for today's class is Myasthenia gravis. This is a case presentation. It will be presented by one of the residents from Assam Medical College, Dr. Alankrita. And it gives me immense pleasure to introduce to you Dr. Jenil Seth, who is from LV Prasad, Hyderabad. Welcome, Dr. Jenil. So let me introduce you to Dr. Jenil Seth. He has completed his basic medical training from Nair Hospital, Mumbai, followed by a residency in ophthalmology and fellowship in pediatric strabismus and neuro-ophthalmology from LV Prasad Eye Institute, Hyderabad. He is currently a faculty at Child Sight Institute, LV Prasad Hyderabad. And since the last 2 years, he has been practicing pediatric ophthalmology, strabismus, and neuro-ophthalmology. His core areas of interest include complex strabismus, neuro-ophthalmology, and neuroradiology. So welcome, Dr. Jenil Seth. And with that, I would also like to introduce you to some of the members of YOSI Assam. We have with us Dr. Dipanjan Ghosh, who is the Secretary for the state, and also Dr. Himadri Chaudhary, who is the Vice President of the state. So thank you so much. Dr. Jenil, should we start the session?
Yeah, thank you, Dr. Vinitra, for having me, and thank you all to all the members for organizing this. And good evening, all. Yeah, we can actually go ahead with the case, please.
Yeah, Dr. Alankrita, you are good to go? Yes.
Good evening to all the participants of YOSI. Myself, Dr. Alankrita Hajarika, a second-year postgraduate resident from Assam Medical College and Hospital, Dibrugarh. So let's proceed. Can we proceed with today's case?
Dr. Alankrita, you are having some problem with your
Yes,
presentation?
ma'am. Yes, ma'am. I'm having some problem with the connection.
Okay.
Ma'am, I am not able to show the screen. It's written as post disabled participant screen sharing.
I'll just do that. Yeah, give me a second. Please try now.
So proceeding with the case, my patient, a 14-year-old male child hailing from North Lakhimpur, Assam, a student by
I can't see
occupation.
the slide yet. Yeah. Please try to share it again.
So is it visible now?
Yes, it is loading. I think it will be there in a second. Yeah, perfect. Just make it full screen.
Yes. So is it visible now?
Yes, please go ahead.
My patient, a 14-year-old male child hailing from North Lakhimpur, Assam, a student by occupation, belonging to lower middle socioeconomic class, Hindu by religion, presented with the drooping of both the upper eyelids, the right eye being involved more than the left eye since last 2 months. He also complains of double vision since the same time, that is the last 2 months. On elaborating the history of present illness, the patient complains of drooping of upper eyelid of both the eyes since last 2 months. The right eye is involved more than the left eye. It was gradually in onset, progressive in nature. It worsens typically towards the evening, and it was first noticed by his friends and family member. This is the image of the patient in the morning, and this is the evening image. The drooping of the upper eyelid, it was gradually, it relieves or even diminishes after taking rest.
Divakant, are we having some problem with the sharing of screen?
Am I audible now? Am I audible
Yes,
now?
yes. Alankita, please continue. Go into slide share mode and continue.
Ma'am, in the coming to the past history, there is no similar history in the past, no history of any systemic diseases, no history of any ocular disease or surgery in the past. Personal history, the patient is non-vegetarian by diet, his sleep, appetite, bowel, bladder habit is normal, he is not addicted to any known substance, and he is not on any systemic medication. Treatment history, no systemic history of any disease in the past for which the patient needed treatment or was admitted. All other members in the family are enjoying good health. There is no known significant allergy history. The patient has been immunized as per the national immunization schedule, but there is no history of any post-immunization reaction. Coming to the general examination, the patient was conscious, alert, and well-oriented to time, case, and person. He is an averagely built child with a normal nutrition. His height being 5 feet 2 inches and weight is 48 kg. He was afebrile at the time of examination. His BP was 110 by 70 millimeter of mercury. Pulse is 88 beats per minute, regular, normal in volume. There was no pallor, edema, clubbing, icterus, or cyanosis at the time of examination. No lymphadenopathy or palpable glands were found, and examination of the other systems were found to be within the normal limit. Local examination, the head posture is normal. Facial asymmetry was present. Visual acuity in the right eye is 6/9 and 6, and in the left eye 6 and 6. Coming to the examination proper of the right eye, the eyebrow was raised. Frontal crease appears to be normal. There was no brow laxity. Eyelids, there was drooping of the upper eyelid. Margin reflex distance 1 was 2 millimeter, MRD2 is 5 millimeter, and margin crease distance is 10 millimeter. LPS function was tested by a Volk's method is 14 millimeter. Margin limbal distance is 8 millimeter. Lower lid margin thus touches the limbus. The Bell's phenomena on examination was found to be normal. The palpebral aperture is narrow, vertical length being 7 millimeter. The horizontal is 30 millimeter. The eyeball on examination, the extraocular movements was normal. Conjunctiva is clear. Cornea is clear with intact sensations. Anterior chamber appears to be normal. The iris is normal. Pupil is round. The diameter being approximately 3.5 millimeter. It's regular and reactive to light. The lens appeared normal. Examination of the left eye. The eyebrow appears to be at a lower position than that of the right eye. The frontal creases appears to be normal. There was no brow laxity. Eyelids, there is drooping of the upper eyelid. MRD1 is 3 millimeter. MRD2 is 5 millimeter. Margin crease distance is 9 millimeter. The LPS function by Volk's method was 40 millimeter. Marginal limbal distance is 9 millimeter. The lower lid margin just touches the limbus. The Bell's phenomena was again found to be normal. The palpebral aperture here also it is narrow of around 8 millimeter. Horizontally it is 30 millimeter. Extraocular movements was normal. Conjunctiva is clear. Cornea is clear with intact sensations. Anterior chamber appears to be normal. Iris is normal. Pupil is round of approximately 3.5 millimeter in diameter. Regular and reactive to light. Lens was normal. Coming to the clinical test, fatigability test came out to be positive. Sleep test was also positive. Open to speech sign was positive. Eye spec test after 2 minutes came out to be positive. Two pharmacological tests were done, the phenylephrine test and neostigmine test, both of which revealed positive result. This is the picture before eye spec test, and this is the picture after 2 minutes of the eye spec test. Now, from the history, clinical examination, and the clinical test, we come to a series of differential diagnoses, which includes myasthenia gravis, pseudotoxis, congenital ptosis, muscular dystrophy, Lambert-Eaton syndrome, chronic progressive external ophthalmoplegia, neurogenic ptosis, and botulism. Provisional diagnosis can be considered as a juvenile ocular myasthenia gravis involving both the eyes. Now, coming to the investigations proper, RE blood with ESR came out to be normal. RBS is within normal limit. Serum electrolytes was also within normal limit. The liver function test is normal. Thyroid profile came out to be normal. RE urine had normal findings. ECG acetylcholine receptor binding antibody was 0.50 nanomole per liter, which lies in the range of equivocal. Radiological investigations, CCT thorax, the thymus is visualized with homogeneous echo structure with normal regular margin with maximum anterior posterior thickness measuring 1.9 cm, which is considered to be normal according to this age group. The CECT nape was also revealed also normal study that thyroid gland is normal in side position density. There was no any focal nodule, cyst or calcifications. NACT brain with orbit reveals no obvious abnormality. Chest X-ray PE view, the hilar lymph nodes appears to be normal, no growth, mass or any calcifications were seen. Now, from the meticulous history, clinical examinations, investigations, we come to a diagnosis, final diagnosis that it is a case of juvenile ocular myasthenia gravis involving both the eyes. Management. This case was treated with tab pyridostigmine 600 mg. It was given one tab 3 times daily before meal to continue till further advice. Also, for the average bill of the patient, serum multivitamin was given 10 ml daily after food for 1 month, and tab lansoprazole 30 mg 1 tab daily in empty stomach was given initially for 2 weeks. The patient was advised for follow-up 2 weeks after the initiation of the treatment, and this is the result, which showed relief from the previous signs and symptoms. Coming to the discussion, myasthenia gravis is an autoimmune disease in which antibody mediates the destruction of the damage and destruction of the postsynaptic.
Yeah, we would not like to go
Yes,
into the
ma'am.
discussion now. We would like to discuss the case.
Huh?
Okay, we would like to discuss the case rather than going into the theory part. So can you please start with
Yes,
your
ma'am.
first slide? I would like to request Dr. Janil to give his inputs. First, we would like to open with the case presentation itself. So would you like to say something about what is your input about the way the case was presented or how it should have been presented? Would you like to help the students with that? Dr. Janil?
Yeah, so if I may, I can ask Alankrita some questions.
Yeah. You can please go
Yes,
ahead
sir.
with the, yeah.
Hi, Alankrita. So this 14-year-old came to your clinic with
Makes sense.
bilateral. So bilateral asymmetric ptosis, possibly what I could make out from
Yes,
your
sir.
measurements and the photos. And the
Yes, sir.
chief complaints were two. The second chief complaint was diplopia, and none of your examination addressed that except for extraocular motility was normal. So why do you think the patient complained of diplopia with the normal extraocular motility? Can you give some insight on that?
So maybe, so it may be due to the fatigability of the extraocular muscles. The diplopia was mainly towards the evening. It's more towards the evening, and it relieves after taking the rest. So it might be due to the fatigability of the muscles that leads to diplopia.
Okay, but did you happen to do any test in the clinic which you would elicit diplopia, or did the child say that the
Yes, sir.
diplopia was present at the time of presentation?
Yes, the diplopia charting was done. We did it both in the morning and the evening, but even in the evening, it came out to be normal.
Okay. And do you think in such patients, even with normal extraocular motility, the patient would still have diplopia? Is it possible?
So usually it's not possible, but since the fatigability of the muscle can lead to diplopia.
So what do you think would be diplopia charting is an excellent idea. I agree. Doing a simple test like a red filter test also would be very easy to elicit if the patient has diplopia, but it would dissociate the images. It's a very most dissociating test. However, in such patients, when you follow up, it's very important. Apart from your ptosis measurements, looking for fatigability and repeating the ISPAC test, it is important to do the cover test for the patient. So strabismus is a very common complaint. Is the second most common complaint after ptosis, and always cover test needs to be done and documented in all directions of gaze. Maybe he is orthotropic in primary position, but he would be small esotropia in one of the gaze, or maybe vertical strabismus would be there in one of the gaze. So it's always very important, even if the child has central Hirschberg reflex test, and even if the child complains of motility, complaints of diplopia with normal ocular motility, cover test is always very important, and measurements with prism bar cover test in all the follow-ups is must in such cases when you suspect that this would be an ocular myasthenia. So your
So this was missed in my case.
so when the patient presented to you in the evening, was there any worsening of the symptoms you noted in terms of ptosis? Was it worsened?
Yes, sir. So I placed a photo here, the morning and the evening picture.
Okay,
So
so the
this is it.
photo is one is okay. All right, maybe you could see some worsening of the doses, but one is more of magnified as compared to the other. All right, one of the good ideas is to actually call the patient twice. Another basic test what you would do is on the bedside test, which you have already elaborated and mentioned, is to do a fatigue test and ice pack test. So how reliable is the ice pack test? Do you know the sensitivity and specificity of the ice pack test in myasthenia patients? So if ice pack test is positive, how sure you are that it is myasthenia?
So actually, I forgot the numerical values, but after the ISPEC test, we will do the antibody test to confirm the diagnosis of the myasthenia gravis.
I agree. Antibody test is it comes
It's
to the
almost,
investigation. We are talking about here on clinical examination, on bedside examination.
yes, it's almost 80% sensitive.
Okay, so it has very high sensitivity and specificity. Amongst the, it is very specific. That is, as specificity is as high as 96%, and sensitivity is also as high as around 80 to 85%. So once your ISPAC test, if done correctly for appropriate amount of time, is positive, then there is a very highly possibility that what you are dealing with here is a ocular myasthenia with or without generalized myasthenia. So you should know these numbers. This should be running in your mind that this is a probability. So what is the duration of ISPAC test? Usually what is recommended to do?
So it's 2 to 3 minutes.
Any specific reason why 2 to 3 minutes is the time? What happens if we place for probably 10 minutes?
Sir, the reason is that if you place the ISPAC over the total clip, it inhibits the acetylcholine esterase. So acetylcholine is not metabolized, and so that's why the doses gets relieved after the ISPAC test.
Okay, no, but my question is, what if you place for a longer time? Okay, so what? All right. Okay, so what would you consider as a positive ISPAC test? So, child has ptosis with probably MRD of 1 millimeter, and a post ISPAC test. What do you expect enough to say that the test is positive?
Sir, the doses. Actually, the symptoms will relieve. There will not be ptosis after 2 minutes of the ISPAC test.
So you are saying that the MRD 1 millimeter will turn into MRD4, MRD1 we are talking about will turn directly to 4 or 5 millimeter. Is that what you are saying?
No, sir. No, it may be up to 2 millimeter or up to 3 millimeter, not completely relieved.
Yeah, so there is a cutoff, right? So you have a lid excursion of more than 2 millimeters after ISPAC test. That is what you will call a positive ISPAC test.
Positive
So excursion of lid or the elevation of lid of more than 2 millimeter from your documented evidence is what you will call that it is a positive ISPAC test. This much. And another important thing is to do it on both the eyes, even if there is no bilateral involvement. So the other eye can control as can be served as a control eye. When you have bilateral involvement, obviously you will do on both the eyes. But when you have uniocular involvement, you should always do in both the eyes so that its control is there in front of you to compare to how much amount of excursion is happening. And you know that you are on the right direction and right time for the ISPAC test. Any other lid signs do you know of in myasthenia patients, both pediatric as well as adults? What are the lid signs you are aware of? Ptosis is what you have described everywhere.
Congenital ptosis.
No, lid signs in
Pardon, sir?
myasthenia. Yeah, can you hear me? I'm asking
Yes, sir. So in congenital,
yeah, please go ahead.
yes, sir. Hello.
Go ahead. Hello.
Sir. Yes, sir. Yes, sir. So lead signs in congenital ptosis, the lead crease will be absent there. Sir, again, the various lead tests that we do are the marginal reflex test, as mentioned earlier. The margin crease test, the margin limbus distance. We also measure the palpable feature.
No, you go ahead with the lid signs. For example, the Kogan lid twitch sign.
Kogan lids.
Yeah.
Yes, Kogan twitch sign was done in this patient, and it came out to be positive in this patient.
Okay, can you quickly tell us how do you do it, and what is your examination findings in Kogan lid twitch sign?
Sir, first we ask the patient to look forward, and then we ask the patient to look down for around 20 seconds, and then when the patient looks up, there is an overshoot of the ptotic lid.
So the patient looks up for 20 seconds, and then after that, where does he look?
Sir, first the patient looks towards a distant objects. Then we ask the patient to look down for 20 seconds. And then when we ask the patient to look up, there is an overshoot of the ptotic lid.
Okay, it could be said in a more better way. Okay, all right. So why do you think this happens? Does it happen normally?
No, sir.
Okay, so why particularly in myasthenia patients you would suspect this to happen? What do you think is going on that there is a leg excursion once the patient sees from up to down to straight?
So actually, I don't know the.
Okay.
Not aware of the correct
Okay.
mechanism.
Other participants can also chip in to like answer the questions. It's not like only I mean for her. So the rest of the participants and the students can also go in with an interactive session. So I would request others also who may know the answer can please help out. So Alankrita, I would like to say one thing for the Kogan lid twitch, and you let the patient look down and then in the primary gaze, not like distance and then down and up. It should be in the primary gaze. Okay, so that's how you see the Kogan lid twitch sign.
Okay.
Yeah. So we have a lot of students here, so anybody can volunteer to answer. Okay, I think Daniel, we should move ahead with the question. Your question was, why do we see the Kogan twitch?
Yeah.
Yeah.
If anyone else can take that, no one else wants to take. I mean, it's a common, it's a DNB resident level question where you will be asked in the exam, what do you mean by coconut? If you know about the sign, you should also know about what is it. So why do you think, I mean, let us understand, why do you think the fatigability is setting in so fast? So on average in a clinical examination, you might have a stopwatch or you might have a clock to take 20 seconds. But you know, in a practical way to say, when you're trying to do your fatigue test, is when you're trying to give an object to the patient in the up gaze and you try to maintain that. You know, in a clinic, the way we are taught is you might not have a clock next to you to keep a timer on. But the moment your hand starts hurting, that's the time that almost the time is up, and that is the time when you will see the fatigability setting in and the lid started to droop down. All right, so you know what is the let us go to the basic mechanism. Probably I saw some of your discussion slides, so I'm sure you're aware of. So what exactly happens in myasthenia gravis, or let's say what exactly happens in ocular myasthenia gravis? So probably from that we'll try to understand what happens in Kogan with sign. Alankrita or anyone else?
Yes, sir.
What is the pathophysiology of myasthenia gravis? What is the basic
So the
pathophysiology?
it is an anti-VD mediated post-synaptic damage of the acetylcholine receptors.
Okay. All right. So how does it work? How does the single motor synaptic unit work? What happens in order to lid to elevate? What will happen at the synaptic level?
The action potential has to be radiated so
Yeah,
as to work for the muscle.
So what does acetylcholine do, and what does acetylcholine esterase do?
So the acetylcholine, it binds to the acetylcholine receptors, and the acetylcholine esterase, it metabolizes the acetylcholine neurotransmitter.
Excellent. So what is the problem within myasthenia patients? They do have an antibody, right? And they do have an antibody which has affinity
Yes,
towards the acetylcholine receptor. So which does not allow the
receptors.
acetylcholine to bind to the acetylcholine, enough acetylcholine receptors. And this is what exactly is happening
Yes.
during the fatigability which you are testing it. So once you are testing for fatigability and ask the patient to look in the down and the primary position once again. Once the patient relaxes, it is the excess of the acetylcholine which is going to act on the acetylcholine receptors, and that is responsible for the lid excursion or the twitch, what we call, and that is known as a Kogan's lid twitch, the name after the scientist who found out that this frequently happens, which should not happen otherwise. So there is a buildup of the acetylcholine when the eye relaxes in the down gaze, and you tell the patient to look in the primary gaze, and when the patient comes in the primary gaze, and because there is already the action potential has reached its peak, the excess of the acetylcholine is going to act on the remaining receptors, and there is going to be excursion of the action potential peak causing slight elevation with falling back of the lid to the normal position again. So that twitch
Normal
is the
position.
Kogan lid. That is the reason why this would happen. So this is also one of the lid signs. And there are other lid signs.
Yes.
Are you aware of other lid signs, eyelid signs in ocular myasthenia? Do you know something
Lead-like
about?
sign is there which is absent in this patient.
I'm sorry.
Yes, sir.
Other eyelid signs in ocular myasthenia. You spoke about ptosis. You spoke about Kogan lid twitch. Are you aware of other eyelid signs in ocular myasthenia?
So lead-like is also there, but this is not present in this patient.
What I could not hear you. I'm sorry. There was an interruption. What is there? Hello.
Sir? Yes, sir. Am I audible?
Yeah.
Am I audible, sir?
There was an interruption. I could not hear you. You were saying something. Please go ahead.
Yes, sir. So I was telling that the lead-like sign is also there, which is absent in this patient.
Okay. All right. Okay. So let's move on. Dr. Niluptana, you want to add something? You want to ask something?
Not right now, but I have few questions on the later part. You might have frontalis overaction also on the other part, but that will not be considered in the lid sign.
Yes. Anything, Alankrit or anyone else to the orbicularis? Do you think the orbicularis?
Yeah. The orbicularis oculi weakness will be there. So
yeah. So they
you can
are
easily open up the eye. So that's known as the peak sign. Yeah.
Peak sign.
Exactly. Yes,
Peak sign.
exactly. Yes, that's known as the peak sign. And we have Dr. Aditi, who is one of the oculoplastic fellows in our institute. She has talked about the Bien-Fang's sign. Am I right, Dr. Aditi? Bien-Fang sign?
Yes, ma'am. Yes, ma'am. It's similar to the Kogan eyelid twitch, except that you ask the patient to forcefully close the eyelid. That relaxes the LPS and also it causes fatigue in the orbicularis. After that, when the patient opens the eyelid, a similar twitch like the Kogan twitch is seen. So similar sign is the Bien-Fang sign.
Yeah, okay. Thank you so much. So we have the Kogan twitch. We have the Bien-Fang, which is similar to Kogan twitch. Then we have the peak sign, which is because of the weakness of the orbicularis oculi. So that you ask the patient to close both the lids tightly shut. And then when you try to open the lid, it opens up really easily. If you try to open one eye, the other eye may be closed, but you can easily open the eye that you want to test. So that is one. Then you may also have overaction of a frontalis in the affected eye, where you can see that there is crease in the frontalis and it has increased, or the eyebrow has been in an upper position compared to the other eye. Yeah. So those, I think I can think about that. Dr. Janil, do you have any more?
no. I
There
think
is definitely weakness of the levator in upgaze in these patients.
Yeah. I was looking for those answers only, actually. All the lid signs which are, I think all of them, Bien-Fang sign and as well as peak sign or peekaboo, what different authors have labeled it. Everything you would see in just one simple examination technique. And you tell the patient to close forcefully, and everything else you can elicit subsequently. So these are common clinical tests. I mean, you would directly jump to practically speaking to IcePack test, but it is always good to know and always good to understand that why it is happening. Another important thing about, now we spoke a lot about ptosis, which is one of the most common presenting symptom almost in close to 80% of patients. But the second most common is diplopia and strabismus, which is around 40 to 60% of patients would present with this in ocular myasthenia. So in terms of diplopia, so what do you think would be anyone, probably Alankrit or anyone, what is the earliest, from the terms of pathophysiology, the earliest finding you would note in ocular myasthenia? The patient has diplopia. Like in this patient, the patient has diplopia, but you find an normal ocular motility. You can elicit a fatigability test by telling the patient to have a frequent, saccadic movements from right to left, left to right, and up and down. And then you might try to notice if there is some strabismus which is induced because of the fatigue which is set in. Probably
Fatigue.
do for 30 seconds or 1 minute. But do you know what is the earliest sign in ocular myasthenia, even before all these signs comes up? Has anyone read about it or come across it? Something which we cannot elicit in the clinic, something which needs a laboratory setup, something which we do it in nystagmus also.
Caloric test.
I'm sorry? Someone was saying something?
Please come again. Caloric test. Okay, nystagmus movements at extreme gazes.
Nystagmoid movements,
At extreme
probably,
gazes.
okay, that is because of the fatigability that you can see about abducting nystagmus at times, which is known
Yeah.
in myasthenia. But that is probably a sign which you have noted. This is all happens even before the symptoms, or maybe sometimes even before the signs you could relate it. So so probably in interest of time,
Single muscle fiber twitch.
single from
Single muscle fiber twitch.
it is very difficult to elicit from the ocular point of view. What you are talking about is right, and you can do an SFEMG, which is very sensitive test. But this is what we are talking about is generalized myasthenia. My question is pertaining to something in similar to ocular myasthenia. What do you think you can actually elicit, or you can do in a laboratory setting? So if you have a electrooculogram, you can actually, with search coil, we can actually measure the intersaccadic velocity difference. And the intersaccadic velocity difference is the earliest sign you would see in ocular myasthenia. That is, the saccadic velocity between the two eyes would be different at 10 seconds, 20 seconds, 30 seconds. So you will see fatigability setting in, something similar to single muscle fiber myography, something similar to RNST, repeated nerve fiber stimulation test, where you see fatigability setting in. So that would be the one of the earliest sign of myasthenia. That is what in published literature, if you all can go back and read about it, it is interesting to know what happens and to understand more about at a very at a very basic level of how myasthenia happens and why does it happen. Anyway, probably not very important from exams point of view, but you should know. So intersaccadic velocity differentiation is one of the very earliest sign before other things in it. If Alankrita can go to the differential diagnosis slide, if she's around. Yeah, so you did your ice pack test, you did fatigability test, you called the patient
Yes.
twice in the morning and evening to look for variability. So one of the reason that's
Yes.
actually an excellent way to, if the patient is able to come, that is one of the excellent way to actually see the patient, in morning and evening, both the times, or probably on the same day or some other day, to look for variability. So variable ptosis, variable diplopia, variable esotropia or exotropia or vertical tropia. So much of variability, this is where you suspect ocular myasthenia. No, I was saying the differential diagnosis slide.
Yes.
So when
So
you
is it
have done
visible?
yeah, now I can see. Thank you. So when you all your provisional diagnosis is there, why do you think you have to give so many differential diagnoses here? Why do you think it would be congenital doses, uh, neurogenic
Sir,
doses? I don't.
sir, consider. Sir,
Do you think it is a good idea to give all the differential diagnosis in this case, because the differential diagnosis will be pertaining to the case, right? It's not a
yes, sir.
differential diagnosis of a ptosis in a child. It's a differential diagnosis to this present case where you have a provisional
Yes.
clinical diagnosis in mind. So pseudodosis, of course, it is not there, right?
Yes,
Even
sir.
you would agree. Congenital ptosis also, you would agree. You might have seen the old photographs and you have seen the other lid signs also, no
Yes,
lid
sir.
lag, no lid lag on down gaze, and crease is not lifted up. Muscular dystrophy, unlikely. Child is around mid-teens with no wasting of the muscles, right?
There is no easy fatigability and under muscle wasting in
Yeah,
this
so in
case.
this case,
So
I think
which
it
is
is
excluded.
almost pretty clear that what we are dealing with, and it needs to be supplemented with more stringent test. ISPAC test, like we discussed, is very, very specific and sensitive. But now whether to do neostigmine test in these children or not is some would do, some would not. But ideally, yeah, you want to do neostigmine test and confirm it. So this list of differential probably botulism very unlikely. Okay, it would have paralysis, ascending paralysis.
Yes, and there was no history of any fever, vomiting, or diarrhea.
Exactly. So in this case, I think it would be inappropriate to list such a huge list. I mean, if textbooks will say everything, it is a different approach. But in this case, no. And coming to the investigations, the 2 slides below it. So why did we investigate for all the blood investigations? I mean, for
Sir, it was RE blood with ESR was done to rule out any inflammatory myopathy. RBS was done to rule out diabetes mellitus. Serum electrolytes along with the liver function tests were done to rule out any paraneoplastic syndrome that might be associated with the doses. Thyroid profile to check out any thyroid ophthalmopathy or any malignancy in the thyroid gland that is associated with doses. And RE urine is also a part of the paraneoplastic syndrome. ECG was done as because the neostigmine test was done. So before that, ECG was done to rule out any cardiac abnormality. And acetylcholine receptor binding antibody, this was done so as to establish the fact that we are dealing with a case of myasthenia gravis.
Okay. Okay. Amongst all this, what do you think will be the most appropriate, relevant investigation? Obviously, ECG will be required from the fitness point of view by the anesthetist for giving neostigmine to the child. But related to ocular myasthenia or generalized myasthenia, what is the most appropriate investigation which is there here, which has some association with myasthenia in some percentage of patients?
So it is the acetylcholine receptor binding antibody test.
That is for the probably for diagnosis and other things which you probably will come into. But otherwise, on the list of investigations, the 2 slides which you have, what do you think is relevant to your case? More common in adults than pediatric population, but we are discussing about myasthenia in general. So what do you think is more relevant? Do you think serum electrolytes and diabetes mellitus is something which you have in your mind, looking for paraneoplastic syndrome? No, right? That is not in
Yes,
your differential.
yes.
It is always okay to do, but we are going in one direction,
Yes.
one approach. So we should know the approach in what we are thinking. We cannot do all the investigation at once.
This was also done as a part of the routine investigation, which is it.
All right, I agree. No, there is no problem in doing this routine investigation. The investigation which has been done, what do you think is one has a relation to your current case? Do you think that the thyroid profile has some relation to the current case, ocular myasthenia? Is there any?
Yes, sir. This thyroid malignancy is often accompanied by doses.
Thyroid malignancies. Okay.
Graves ophthalmopathy also.
So let us talk about something which is more so basically we are talking about autoimmune thyroiditis.
Thyroiditis, yes.
Yeah, so we are talking about Hashimoto's, or let's specifically generalize. We are talking about autoimmune thyroiditis.
Thyroiditis.
Present in how much percentage of patients with ocular myasthenia or generalized myasthenia? Any percentage you are aware of how many patients would be having this, and why? That is the relevance of doing thyroid test, right? You are not looking for malignancy here. You are looking for a possibility association between thyroid.
So nearly half of the patients coming with thyroiditis may present with myasthenia gravis.
So you're saying 50% of the patients?
Yes, sir.
Okay. Have you seen any such numbers like in your clinic? That you see every 1 out of 2 or 5 out of 10 will have?
So we don't get ocular myasthenia at a frequent basis. Neither do we get thyroid.
Okay, so the literature is again varied depending on geographical distribution and other things. West Caucasians versus Southeast population, Southeast Asians. So around close to 30% of the patients, or you can say 1/3 or less patients, would be associated with autoimmune thyroiditis, because this is again an autoimmune condition. So 30% or less number of patients would be an association of ocular myasthenia or generalized myasthenia with autoimmune thyroiditis. There are many things into it, but from our this case perspective, we'll stick to only this number and not more discussion into it. So one last before Dr. Niluptanna can take over. So in this patient, if I tell you that this patient also has thyroid eye disease, what is one sign which you think which will give you a clue that thyroid eye disease would be present?
Sir, it will also present with proptosis along with this sign.
Okay, proptosis may not be present. What is another thing you would think of? You have a history of diplopia. You have a history of variable ptosis in one eye, but there is something else also what you notice in examination.
Sir, there will be lead-like sign.
Lid lag. Okay, lid lag where? In down gaze, huh?
In down gaze, yes, sir.
Okay, something more obvious.
Sir, CT doesn't get.
I mean, you're talking about lid. I agree with your point, but there's something more obvious you would notice on just examine on the photograph only. You can just see, and you would think, okay, this is thyroid with something else, or this is just thyroid eye disease and not with something else. Something when every patient of thyroid eye disease you should also do. So when you have a very obvious lid retraction, which is probably
Retraction.
yeah, so you have a lid retraction with a suspicion of ocular myasthenia, because the patient has easy fatigability. The patient has probably after ptosis a easy eye spec test which is positive, and he has a variable diplopia in presence of normal ocular motility without proptosis. This is where you would think of an association of thyroid eye disease in such patients. Lid retraction is very unusual in ocular myasthenia. And the last question, do you think there is a pupil involvement in such patients?
No, sir. If people would have been involved in case of third nerve or something, it will be either miotic or it will have been either dilated. The people would have been dilated.
Excellent. So for just from the exam purpose and just for clinical purpose, and there are some reports of mild pupil involvement here and there, but there should be never pupil involvement in ocular myasthenia. If you see any pupil involvement in terms of anisocoria or afferent pupillary defect, you have to start thinking of some other thing is also going on, and it is just not ocular myasthenia. Pupil involvement is never. There has been some reports, but otherwise it is never from our residency, our exam point of view, and our examination point of view. Pupil involvement should always also very specifically mention about pupillary findings in such patients. Specifically for all direct, indirect, near reflex, everything should be mentioned very thoroughly in such cases, so that you are telling the examiner or the person opposite to you that this patient does not have pupil involvement, is only extraocular motility or ptosis. Dr. Niluptanna.
That was an excellent discussion, Dr. Janil. I think you have almost covered everything that has to be seen in a case of myasthenia, especially in this pediatric age group. From my side, I have a few questions, and rather than questions, I would like to throw a light on some of the points here. So, for example, when you are presenting a case of ocular myasthenia or myasthenia gravis in general, then when you are coming at the history, you have taken certain history, like he doesn't have you said that he comes from a low socioeconomic status, then that was his family history, and then you spoke about that he has no other similar systemic illness or those kind of diseases. But as Dr. Janil has pointed out, whenever you are focused on a particular case, like what you really want to present, you need to know why you are asking those questions. For example, in the initial examination, you may have skipped those questions, but later on you can go ahead with the leading questions in these cases. For example, in this part of the country, you will have certain things like neurocystic sarcosis most common. And sometimes we should know one thing, that myasthenia gravis is a great mimicker. Okay, it doesn't like, for example, you have a lot of differences starting from your ptosis to your CPO to everything, like neurogenic problem also. So in that situation, if you are looking at the socioeconomic status, that means you are trying to rule out the infections also. And if you are trying to rule out the infections, then you have to investigate in that course of line also, because your RE blood with ESR will not show anything. you have to do a CBC with your eosinophil count also, but sometimes the absolute eosinophil count is also required. It may not be raised. So those things in terms of laboratory investigations pertaining to the question that you have already asked in the history. So that is one. Then regarding, since you know that your provisional diagnosis is going to be myasthenia, so you should also, even if it is a CPU or whatever, then you should know that these patients, you have to ask questions like, is there any dysphagia, is there any dyspnea, or along with the diplopia, because these are the proximal muscles that are affected, and then the generalized weakness comes in. So you have to ask this head and neck muscle involvement also in these children. So that is one. In children, you need to take a history of fever, is there or not. Then in the examination part, yes, you need to take in account the visual acuity. He has already mentioned about the cover test. Then also the involvement of the pupil, because you want to rule out the neurogenic causes. So that is one. And yeah, this almost covers everything. So you have taken one history of dysphagia slurred speech. Yeah, that is very great, and even fever in the recent past. So in case of any, So in case of any surgery, rather than going ahead with any surgery, I would like to specify that was there any surgical scar in the thorax or any part of the midline of the chest, to know if the child has undergone any thymoma surgery. Yeah, so that would be really helpful. And basically the principles of doing the eye-spec test or even the fatigability test. And if you feel that you do not have a diplopia charting or things like that, you can ask the patient to look up for some time, and then you see if there is increase in the diplopia or not. So those things also you can go ahead. There is also importance of looking at the fundus for seeing any pigmentary changes in the fundus. So these things would really help, and I would say that you have almost covered most of the part, and it is really helpful. But what I want to point out is that when you are talking about the variable ptosis in case of myasthenia, you don't say congenital ptosis in the children. It's not the correct way to say congenital ptosis in case of a myasthenia, because the ptosis is variable. One. And you need to take a history whether waking up in the morning, does he feel refreshed, and towards the evening, does it increase more or not. And when you are looking at the MRD, that is the ptosis evaluation, that should be that will give you some variable measurements. It will not give you exact measurements because it will keep on changing. Okay, so that is one. And yeah, you have also included, along with the laboratory investigations, you have also included the radiological investigation. Yeah, in the radiological investigations, I would like to say, if you have already done an HRCT for the thorax or CECT for the thorax, I don't think there is a necessity of doing a chest X-ray PAV for the child.
Actually, ma'am, chest X-ray PAV was done as a part of routine investigation in the beginning.
No, you cannot say routine investigation. How can you put a child for routine investigation for so long an exposure? The answer should not be like that. Dr. Jenny has pointed out repeatedly that when you are presenting case, it should be focused on the case itself. It should not be included, right? So what are you trying to see in the thorax? You're trying to see the thymus, if there is any thymoma in the thorax, right? So because surgery for thymoma itself also gives relief from the myasthenia. So those things are supposed to be seen. The CECT neck only for neck gland, I don't think so, or the thyroid gland, I don't think so, because you have already done the thyroid test for this patient. And NECT brain with orbit, what was the relevance of this? I would rather think the relevance of this would be more of neurologic and infection. For example, neurocystic sarcoidosis, or if you are going into a ophthalmoplegia, for example, a third nerve or a fourth nerve or sixth nerve involvement, any lesion in that area. So that would be, and I would suggest that it would be helpful if you do an MRI of the brain rather than a CT scan of the brain in the child. So that is all about the investigations. Dr. Janil, would you like to continue with the management of the child?
Yes, Dr. Nilanjan, I agree with all the points. I don't think CT, brain and orbit rather than MRI would be better, and it is always good to do, though even you're very sure of, because like you mentioned, neurocysticercosis, you may never suspect neurocysticercosis of the midbrain, brainstem would present something like this. You're not sure about your fatigability, and ice pack test is equivocal, and you need to be doubly sure. So going back to just before we start with the management, one last point on investigation. So to complete the investigation, Alankrita, you had mentioned about acetylcholine receptor antibody test. So if your neostigmine is positive, if your ice pack is positive, you have all the lid signs, and you have seen the patient twice, and you're not documented what fatigability, variability, you are very sure of ocular myasthenia. Why do you want to do the acetylcholine antibody test? How do you think it's going to affect anything in future?
No, so it is just to confirm the diagnosis that whether acetylcholine antibody binding test is positive or not. So that's why it was done.
So if
To
the
establish the confirmed diagnosis.
okay, so neostigmine was positive, and acetylcholine antibody, if you see, it is just borderline high, and
Equivocal.
equivocal. Yeah, exactly. It should be 0.6 more to say it is positive. So what do you think? This is not this is not ocular myasthenia. You would think of something else.
No, this is definitely ocular myasthenia only, but it's just to establish the fact this test was done.
No, but to establish a fact, something to be done is going to confirm your diagnosis. Where your diagnosis is already confirmed, so I'm trying to get to a relevance of doing this. Do tests to have some. I'm seeing so many tests are done, but we want to have some relevance to it. So that's what I'm getting into. Not that it is wrong. What you have done is everything is correct, but the relevance of it. So what do you think has relevance? What do you think? What are you going to tell the parents of the children? Acetyl anticolon body test is positive. It is very highly positive. What do you mean by the parents are going to ask you? What do you mean by it? What are we going to do next? You already told them it is myasthenia. It is confirmed.
Myasthenia.
What does the blood
uh,
blood test change? Anything?
Yeah, the thing is that now it has involved only the ocular muscles, which may turn into a generalized myasthenia gravis. The child needs regular follow-up after this test came out to be equivocal, so he needs frequent follow-ups.
Okay, agree. So basically, why you want to do the antibody test is to know the chances of a conversion to generalized myasthenia.
Generalized myasthenia.
It is more common. So in previous reports, if you go back and see the published literature, the sensitivity of antibody test in ocular myasthenia was very less as compared to generalized.
Less.
But now with new cohort of patients and the newer studies have shown that the sensitivity is much more better, and it is higher as of the relevance of this test in ocular myasthenia. So it tells you about the disease progression. It tells you about the chances of conversion to generalized myasthenia. So a negative test does not rule out ocular myasthenia. Negative antibody test you still have to rely on your clinical examination, on your neostigmine test, and sometimes in some situations you might also want to rely on your therapeutic response to your treatment. That means you start the patient on treatment because of a very strong clinical suspicion. If the patient responds to your treatment, in a specific period of time, which will come to what should be that time, then you are still now sure, okay, what we are thinking is that, and it is okay, in spite of all the blood investigation coming out to be negative. Also, if the antibody test is very high, that is when you would think of doing a CT thorax to rule out thymic hyperplasia or thymoma or thymic hyperplasia. There are many things. So in that, this gives you relevance of thinking what you want to do. You cannot keep on doing CT thorax in all the child, like Dr. Niluptanna was also mentioning. So every test is going to have relevance to its next step, to the future of the condition. So that is how we are going to go step by step. So it has this relevance. It's just not to complete your diagnosis. Your diagnosis is anyways complete when you call the child twice, did ice pack, everything, you did neostigmine unit. So this has a relevance to the future. So how management, I was looking at it. So when the patient came to 2 weeks, I could see some strabismus. I don't know. The photograph tells me. Was the patient complaining of diplopia in that?
No, sir. No.
No diplopia. So he had some variable diplopia before, and patient is on 60 milligram pyridostigmine, 60 milligram for. So what is the recommended dose of pyridostigmine in children?
So it can be given up to 300 milligram.
No, but how do you
maximize
it's a children. Now you have to all pediatric doses are weight based.
So it's like a dose response therapy.
That means I didn't understand. Sorry.
So it's like a dose response therapy. We'll try dosing the patient, and the dose at which it works, we will give the lowest possible dose to that patient.
Okay, so this, what was the weight of this child?
48 kg.
40 kg. So what do you think should be the dose given to this child in a day? This right now you're giving 180 milligrams.
180 milligram per day.
Okay, so if there is a 60 kilo child, then
the dose will definitely increase, and
how much?
will be at the max it can be increased up to 300 milligram per day.
Okay. Anyone else? What would be the dose of pyridostigmine? You have in children, you have to always mention it weight based. In children, it never has to be randomly, right?
Yeah, exactly. It should be weight according to the weight of the child.
Yes, on an average, what you give is actually probably around 3 to 6 milligram per kg body weight, which is in divided doses. So in this child, 3 to 6 is a range, because again, there is no confined figure, but this is what you should know, because if you have a 15 kilo child or a 8-year-old or 9-year-old prepubertal child with suspected ocular myasthenia, which is acquired, not congenital myasthenic syndrome, so in that case, you have to titrate the dose. So dose has to be given in, because you want to look at the response to your treatment. So what you said is true, that you want to give a particular amount of dose and look at the response, and then you can titrate your dose. This we are just talking about purely about doses. So you have around 3 to 6 milligrams. So in this you have given 180 milligrams for a 40. So it settles into this, right? So 40 and 100 milligrams to around close to, you are given around 5 milligram or less than that per kg body weight. Right, 4.5 milligram per kg body weight is given. That is what the recommended dose is, 3 to 6 milligram per kg body weight in divided doses. So you're around giving around 4 hourly or 6 hourly, that way, 3 times or 4 times. And if the patient has diplopia, you would like to add something. Do you think just pyridostigmine is enough for patients with ptosis as well as diplopia or strabismus? Do you think they will respond better with pyridostigmine or combination with something? Anyone else wants to take probably something with the internet issue? Do we often combine pyridostigmine with something else, something to do with immunosuppression? Okay, so probably we have past 11. Am I audible, Dr. Nilukmala?
Yeah, Jenny, you are audible. You are audible.
Yeah, so I think in interest of time, so often we combine. So when you have purely ptosis in a patient with ocular myasthenia, pyridostigmine in the prescribed dose is enough to look for response to treatment. However, in case of whenever you have strabismus or diplopia or ocular motility limitation, in such cases, adding steroid is really important, because they would not often respond to just purely pyridostigmine. So a combination of steroid therapy, the corticosteroids. So combination of pyridostigmine with corticosteroids in the dose of 1 milligram per kg body weight. Again, here there are many. The current consensus also says, if you read the current consensus, it says that it should be half the body weight dose. So if you have a 40 kg child, you should start with 20 milligram, and then you see the response to treatment and titrate according to it. If there is no response to treatment for at least 3 weeks, then you can give a higher dose of 1 milligram per kg body weight. If the child is responding, you can keep on half milligram and then taper it very slowly. So average duration of treatment is around close to 3 to 6 months, and often even 9 months. So that is amount of duration where the patient child has to be on immunosuppression to begin with, corticosteroids. And because in children, because of the chances of diabetes, Cushingoid features, because of growth failure, And hormonal imbalances, you want to take care that you don't want to give corticosteroids more than 25 milligrams daily for a very long time. In that case, if the patient is steroid dependent, so what do you say is steroid dependent? That if once you reduce the dose less than 10 milligram per 10 milligram, the child has remission. Remission as in recurrence of the symptoms or signs. In that case, the child seems to be steroid dependent, and that is where you cannot keep the child on 30 or 40 milligram for a longer time. So that is where you try to include other immunosuppressants. And most commonly used immunosuppressants, do you know what do we use in pediatric as well as adult population, at least for Indian patients, where they respond very well?
Tacrolimus and MMF.
Very good. So tacrolimus, yes, also good, but more easily obtainable and with lesser side effects is azathioprine.
Yes.
Azathioprine and MMF, where Indian patients specifically respond very well. What you have to monitor is two things. One is the complete blood profile as well as the liver function test is what you would keep them on every 3 monthly or 4 monthly to do routinely, so that you do not have any side effects of azathioprine or MMF. So these are the most commonly used drugs. There are other drugs like CD20 monoclonal antibody rituximab in very recalcitrant cases, intravenous immunoglobulins. But these are the situations usually when we talk about juvenile generalized myasthenia and not just ocular myasthenia. Usually the therapy would stop at corticosteroids or the second line of immunosuppressants, which is the steroid sparing drugs. IVIG, plasmapheresis, all would really go in recalcitrant cases, would really go in cases with severe cases where they do not respond to even immunosuppressants. And these are generally we are talking about generalized myasthenia and not purely ocular myasthenia. So probably that sums up in brief about treatment. There are lots to it, but I think this is what one should know when you are approaching a case of ocular myasthenia. Just last question before Dr. Niluptana takes over. Do you have idea of seroconversion rate in adolescent as adult population? Seroconversion means conversion from ocular to generalized myasthenia. Do you know?
Generalized myasthenia.
Do you know the percentage? So it's important to remember these numbers because this is what should be in back of your mind when you are dealing with patients. They will ask you questions that what will happen in future, and if you're not aware of it, and then you don't have an answer for it, right? That's why I was asking you some numbers. It's always good to know. Okay, Dr. Niruptana.
Most of the, especially in children, you see that when the thymoma is present in 10 to 20% of the patient, out of this 10 to 20%, at least 40% converts to generalized myasthenia later on. So that is what I get. Am I right or am I wrong? I don't know. Did I get the numbers right, Janil?
Yes, it's very variable actually, and probably one of the way that there is a Minnesota study where they have looked for a very long time, for almost 30 years, the seroconversion. I mean, these are mostly the adult population actually. A lot of it depends on the seropositivity, whether there are seropositive for acid alcohol, high seropositivity is there, they would likely. But the range is very variable. You can go from 40 to 60%.
40 to 60. That is what they
That's
say.
a very
Out of
variable.
the
Some have reported lesser numbers also. But this is something which you want to keep in mind, and these are all seropositive cases. The conversion is lesser when it comes to seronegative cases. And so that's why, again, relevance to the test, what I wanted the answer from you. So this is why you want to do, not to complete your diagnosis.
Yeah. So thank you so much, Dr. Janil. I hope all of us have gained one thing from here, from this discussion, is that first and foremost is your clinical diagnosis. You really have to have a strong clinical, like the basics should be clear to you. What are you dealing with? What patient are you looking at? And if at all you have forgotten in the beginning to ask certain questions, then go back for leading questions so that you come to a provisional diagnosis, right? Number one. And the relevance of the test that you do should not be routine. The relevance of the test should be focused on the diagnosis that you have made. That is one. And for pediatric age group as well as adults, you look for ocular myasthenia as well as generalized myasthenia. Then in order to rule out other causes like neurogenic causes, infection, or for example, in children, viral infection is also very common. for those things you have to rule out. In adults, CPO is one, and you can also, rather than eternal number, I would say Guillain-Barré syndrome is also another thing that you should look for in adults. So these are some of the takeaway messages. And anything else that you would like to add, Dr. Jenil, or anybody from the participants would like to say something on this point? Or else we can close the discussion here tonight, I mean. But that was an excellent presentation, Dr. Alankrita. You just made an effort because you told me that this patient was in the neurology or medicine unit, and you got a call and you made an effort to see the patient in the morning and in the evening as well. That is really commendable and appreciable at your residency level. So that shows that your dedication towards your passion towards your subject. Thank you so much. And any queries or anything? If any queries are still left out, or you feel, please feel free to go into our WhatsApp group, and then we can take up the questions. Dr. Jenil will be there to answer all your questions if you have any. And anything else? Dr. Divakan, would you like to add something?
No, I think it's really late now, and great discussion. I enjoyed it a lot. And congratulations, Ankrita. Great job. And
thank you, sir.
Yeah, thank you, Dr. General, for joining in.
Yeah, thank you all. Good job, Alankrita. Nice presentation.
Thank you, sir.
So I think we'll close this session. Thank you, everyone, once again. And I would like to thank Dr. Jenil for such a good panel discussion, Dr. Alankrita for such a elaborate presentation, and all the participants who has made tonight's session a successful one. We would also like to thank our technical partners, Sun Pharmaceuticals, and the YOSI group. Our special thanks to you, because this is the first time that we have gone on live on YouTube, and I would like all of you to subscribe to the YouTube Yo channel for further sessions. Thank you so much, everyone. Have a great weekend.